I'm gonna do my best to I'm not treating y'all. I'm gonna do my best to teach about TMS, or Transcranial Magnetic Stimulation. TMS, in my mind, is another one of those magic bullet type of treatments. Because out-of-pocket TMS costs $12,000 to $15,000, but your insurance will pay for it. You can get it free or low cost. It's not a medication, so you don't have to worry about side effects. The side effects of TMS are scalp discomfort, headache. That's pretty much it. So it has such a minimal side effects. It's either going to work or it isn't. Let me say how I normally say it. Either going to work or it ain't. That's why it's very low risk for the patient. So the financial investment tends to be relatively low. The time investment tends to be higher though. So TMS is, in my opinion, one of our better treatments in psychiatry. So I'm going to teach you about two versions of TMS. Traditional rTMS, or repetitive transcranial magnetic stimulation. And then I'm going to teach you about PRTMS, which is a personalized repetitive transcranial magnetic stimulation. That's a mouthful. Let me say it real simple. TMS, all it is technology that uses magnetic fields to stimulate the brain. That's it. It uses magnetic fields to stimulate the brain. Why the heck would that work? Well, it works because we know there's a relationship between magnetism and electricity. Because if you expose a neuron or a nerve cell, which is an electrical cell, it's an electrical powerhouse. If I expose that electrical cell to a rapidly alternating magnetic field, it will force the nerve cell to fire. Or, if we want to talk doctor, it will force an action potential to propagate electrical signal across that cell. Right? However, if I expose a nerve cell to a slowly alternating magnetic field, it will inhibit the firing. Ooh, that's cool. In a lot of ways, the brain is like the most advanced supercomputer that we have right now. Because it works on binary code. It's either on or off. It's a 1 and a 0. Because the nerve cell can't do nothing but fire or not fire. So I have a technology that I can turn the cells on or I can turn the cells off. Okay? And ideally, I'm going to turn the nerve cells on in the region of your brain that helps control your mood if it's not working like it should. So what TMS is doing is we're targeting a region of the brain called the left prefrontal cortex, also known as F3. It's about right here, corner of your hairline, right there. Okay. We think F3 helps regulate the mood. And it's superficial in the brain. It's a region in the brain that's superficial or towards the surface, but it talks to other regions of the brain and deeper regions of the brain to help regulate the mood as well. One cool thing about the brain, and I kind of called it like a binary computer, but it also kind of works like on a quantum level. It's kind of cool because when we stimulate over here, almost simultaneously you'll see the brain firing in other regions of the brain. It's almost like, I know that you're going to fire, so I'm going to fire too, even though we may not be directly connected. So traditional TMS is not ECT or shock therapy, but in a way it's similar because it's forcing the nerve cells to fire at a predetermined rate against the brain's will, resetting how the brain is operating, releasing neurochemicals, because when you fire, you're going to release your neurotransmitters, right? So without all of the problems that come along with ECT, like memory loss and, provoking a seizure and having to do anesthesia and the risk of that, going inpatient and things like that. We can do it in an outpatient setting. Patient can drive to the office and drive themselves home. They don't feel any immediately different. But I know over time, I'm training the brain to fire in a certain way. Okay. So the advantages to TMS, like I said, are one, it's accessibility. So it's FDA approved. Pretty much all the insurances have TMS policies. Of course, it's policy specific. Okay. Two is its tolerability. Just scalp discomfort and potential headache. for traditional TMS. Okay. 3 is its efficacy. One of the strong points of TMS is that, like the other treatments we talked about before, our expectations in the real world are going to be greater than 70% of the patients responding to treatment. And we tracked our numbers in the clinic in the past. Our lowest response rate that we've seen in the clinic has been 72%. The highest we've seen is 80%. If you're tracking 50% reduction in symptoms, okay, and that's a combination of doing counseling and med management and things in conjunction with this, but also selecting the right patients for this. So patients can benefit from TMS on the spectrum of major depressive disorder. Okay, it's actually recommended after 2 failures. So insurance won't cover until they've had 2 failures of treatment-resistant depression. So some patients are going to be early in the algorithm. They may be milder. They want to try 2 meds and they want to try it. And then you have some people that are severe, they've tried 20 medicines. It works across the span of those patients. It's also only approved in adults, so it's 18 and above. But we've also treated children. The youngest I've treated has been 14. Okay, but the insurance won't cover that unless you have some really excellent insurance. All right. Now, age range, the oldest I've treated has been 102 with TMS, okay, with good response actually. However, as patients age, the brain naturally atrophies and gets smaller, and there's more space between the skull and the brain. So I have noticed the efficacy starts to go down as you age, but it's not enough to say it's not for older people, because it is. It works well. Okay. So another strength of TMS is its durability. So we talked about the STAR-D trial teaching us that when antidepressants work for our treatment-resistant population of patients, the time to relapse is typically 3.1 months. But we know from our TMS studies, if we follow a patient after completion of TMS with no additional treatments, over 80% of the patients will still have the results from their treatment 6 months later after completing the treatment, which is great. If you follow them a year, that number drops to a little bit over 60%. So I know the majority of patients will retain the results from TMS out to a year. Okay. And the great thing is, if you need to retreat with TMS and you previously responded, your response rate goes up to 80%. So if I retreat you, you got an 80% chance of it working on round 2. Now, most insurances do not cover maintenance TMS. So maintenance TMS would be, hey, I still feel good, but I want to come back, a couple times a month to get treatments. That's usually not covered. And previously, the research didn't support maintenance TMS. However, a recent meta-analysis has showed that maintenance TMS is actually beneficial, that it can keep people from having recurrence of their depression. However, the patients will need about 5 treatments a month to have any type of effect size for that. Okay, so there's some efficacy for that, but typically it's not covered by insurance, so that can be an out-of-pocket expense for patients. Okay. Now, one of the drawbacks of TMS, though, is it's a one-size-fits-all type of prescription for the patients. All patients get treated at that left prefrontal cortex position, which is commonly called F3. Okay. All patients are treated at 120% of motor threshold. What does that mean? So when patients get treated for TMS, what we're trying to do is provoke an action potential or force a nerve cell to fire, and we do that by using the treatment coil and putting it over their brain, but we don't know if the nerve cells are firing or not if I treat you at the treatment location. Only way I would know if I was doing some type of EEG or something like that, but we don't do real-time EEG. But I would know if I fired over your motor strip. So your motor strip controls voluntary movements, okay? So we target the left motor strip, trying to identify the hand, preferably just the thumb. The reason for that is because the motor strip is predictably arranged. If you remember from med school or PA school, on the motor strip there was something called the homunculus. The homunculus was this drawing that showed which cells controlled which part of the body. If you remember, the hand and arm were organized like this. So closer to the vertex was the elbow, and then the forearm, then the pinky, on down to the thumb. So the tragus is the external landmark that tells us where the motor strip is. So what we do in TMS is we place the coil, We line it up with the tragus, we put it over where we expect the hand to be, and we run the pulse into the brain. And if it's the energy sufficient to cause the action potential, we'll see hand movement. Okay. So, and what we do is we try to isolate the thumb, because the thumb correlates with where the left prefrontal cortex is. That's the traditional method of figuring out the prescription for the machine. However, there's another method called the beam method, where we do a series of measurements to estimate where this is. So it's less important to find the thumb. Okay. So once we figure out how much energy is necessary to put into the brain to cause a nerve cell firing, which we see with this hand movement, whatever that number was, we treated 120% of that. That's to make sure that the nerve cells, when we're stimulating them to fire, that there's a high chance that they're going to fire because we actually slightly overdosed them. Okay. Everybody getting the FDA approved protocol gets 120% at that left prefrontal cortex for 36 treatments. The average treatment is about 17 to 20 minutes with traditional protocols. Now there are other protocols. There's something called the Saint protocol, where patients get a treatment on the hour, every hour, all day long for 1 to 2 days. That is not FDA approved, but it works in over 80% of the patients. So it's just 1 to 2 days of treatment, and it's been shown to help with treatment that's not FDA approved or covered by insurance. There's also something called theta burst. Theta burst is when you get like a whole bunch. It's like, think of it like if traditional TMS is kind of like your old school, pistol, think of theta burst like the machine gun. You're basically going to, and you're going to treat multiple locations on the brain with a lot of stimulation to force the nerve cells to fire. That is also not FDA approved, okay? But it has some efficacy in the studies, all right? There's also something called, so basically when you get this treatment, the patients get stimulated at what's called 10 hertz per second. What that means is the energy that's forced into the brain is forcing those nerve cells to fire 10 times per second, okay? So the stimulation pattern is typically 4 seconds of stimulation, followed by a period of rest for the brain to kind of repolarize and the machine to cool down. So usually 8 to 12 seconds. So a treatment is going to be 4 seconds on, a period of time off. 4 seconds on, period of time off. So they're going to get 40 pulses. Remember, it's 10 hertz per second. So they get 40 pulses each time the machine stimulates the brain. Each treatment, they get at least 3,000 pulses. That's the traditional protocol. Okay. Some protocols will increase that to 3,600 stimulations in a treatment, which makes it slightly longer. But this is kind of what most patients get for unipolar depression. Once again, this is not approved for bipolar depression, only for unipolar treatment-resistant depression. Okay, and it works really well. Okay, but what do we do when it doesn't work for patients? So if it works for 70% of patients, that implies that 30% of patients don't respond to this. So in our practice, what we always try to do is figure out something for the patients that don't respond to the typical treatments. That's where PRTMS comes in, or personalized repetitive TMS. To me, this is the holy grail in psychiatry. Because if you think about anything, and you've heard this story before, if you think about anything in psychiatry, the patient comes in, they say, "Doc, I feel like this, I have this symptom, I have that symptom," and the doctor says, that sounds like, fill in the diagnosis, and then they prescribe medicine. Any other field of medicine, you go to the doctor, "Oh, my stomach hurts, I don't know what's wrong." Guess what they're going to do? They're going to ask you a bunch of questions, hear what your symptoms are. Then they're going to do tests. They're going to do blood tests. They might do an ultrasound. They might do a CT scan, depending on how severe your stomach problems are. They might do a fecal culture. They're going to do a lot of tests and get all the data. And based on that data and your report, they're going to make treatment decisions of what to do about it. And we don't do that in psychiatry. We just haven't had the capacity to. Because I know if a patient comes in and they're ill, and I give them a CT scan, it's probably going to come back normal. And that's not going to change my treatment decision. If I do an MRI, same thing. Even if I do a functional MRI or a PET scan, like the Amen clinics, I may see underactivity, but how's that change my treatment? All I know is, okay, you have depression, but I already knew that. So that's not really impactful. Well, that's where personalized TMS comes in. With personalized TMS, what we do is something called a spectral EEG. EEG is telling us about the brain wave patterns at different regions of the brain. It's telling me how fast your brain is firing, and it gives me, it infers what volume of your cells are firing at a certain speed. So we know that the brain is capable of making different brain wave patterns. So we know if you're asleep, you're going to be making delta waves more than likely. If you just woke up in the middle of the night, your brain's probably making theta waves. What just happened? My brain's not braining. If you're meditating and you're calm, your brain should be able to make alpha waves. It's like 8 to 12 hertz. If you're excited and you're taking the MCAT and you're running out of time, you're probably going to be making beta waves. Your brain's going to be working fast. If you're in a war situation and people are shooting at your face and you can literally see the bullets flying through the air, your brain's going as fast as possible again. It's making gamma waves. I can measure all those things. It's how many times your brain is firing per second. I can pick that up on the EEG. What a spectral EEG does is it captures the speed of the brain in different regions. And now that I know the speed of your brain, I know what's going on in your brain. And now that and since I know what that region of the brain is responsible of doing, I can have an idea of how your brain is operating, what symptoms you have. So for example, if your T3 is showing a lot of beta activity when you're asked to meditate in a quiet room, T3 is your left ear. That's your temporal lobe on the left side. If you have a lot of activity when it's quiet, you probably have ringing in your ears, in your left ear. I can see that on the spectral EEG. For my patients who are depressed, oftentimes they have a lot of slow wave activity in the front part of the brain. I can see that on a scan. And I can predict how efficient the brain is. So when the brain is efficient, it creates what's called an alpha wave. So it looks like this. So let's just take one lead. If this was F3, an ideal brain scan, say if this is the baseline, you'll see, based on speed, you'll see a delta speed, a theta speed, alpha speed, and beta speed. This is measured in hertz. 4 hertz, 4 to 8 hertz, 8 to 12 hertz. Can't write. 12 plus hertz, and then gamma's passing this way. Okay. Ideally, what'll happen is there'll be some nerve cells firing here, but most of the cells, when you're calm, should be in the alpha range. That's ideal. That means that part of the brain is efficient. My brain can idle. It can either slow down or speed up. Okay, that's me meditating. Okay. For my patients when they're depressed, let's use blue, because people when they're depressed, they have the blues. You'll see a lot more theta activity, and then you'll see less activity elsewhere, because the brain's running slow. This is telling me that preponderance of cells are firing in a slow wave pattern, and they're inefficient because they can't make an alpha wave. That means they can't go into a relaxation state. Or, this is very common too, you'll see a lot of beta activity. That correlates with anxiety. That means when you're supposed to be calm, the nerve cells are firing. Right? So we can see this throughout the brain and have an idea of how the brain's operating. And now that we know how the brain is operating, we can use TMS, which has the unique ability to stimulate the nerve cells at a certain speed. So we said at the when we talk about traditional TMS, that people get 10 hertz per second. So guess what? 10's right here. That alpha wave. We're forcing an alpha wave in the brain. That's why people's depression resolves. So with personalized TMS, I'm going to force the brain to go into this alpha range, and we're going to do it with a lot less energy. The reason we can do that is because we know exactly the speed your brain's going at from doing this scan. And I know the firing pattern of the brain. So with personalized TMS, what I can do is I can take advantage of it, but because understanding how waveforms happen. So the best analogy is like when someone's jumping on a trampoline. If I want to help somebody go higher on the trampoline, I'm going to press down on that trampoline at the right time, and it's going to propel them higher up on that trampoline. So the same things happen with personalized TMS. So I know the exact speed that your brain's running. I can pulse you right at the right moment to amplify a wave. So I don't need as much energy to get an alpha wave formed, because I'm using that trampoline effect to build the wave up. The reason that's important is because traditional TMS can get uncomfortable if you need a lot more energy to force your nerve cell to fire. So I can use a lot less energy using that trampoline effect. It's a lot more tolerable for the patient. It's a lot more comfortable, and the patients are more adherent to the treatment. Okay. Also, because I can time it this way, I can treat different locations on the brain that I couldn't treat with traditional TMS, because one of the kind of outlier side effects of TMS is seizure. So if I stimulate over your motor strip with traditional power of TMS, I'm going to provoke a seizure, because it's going to force all those nerve cells to fire, and you're going to have a seizure. With personalized TMS, I'm using so much lower energy. I'm not always forcing the brain to have an action potential. I'm basically just amplifying the waves that are already there. Okay. Therefore, I can treat the F3 location. I can treat right on the top of the head, the CZ location. I can treat the front parts of the brain. So I can treat multiple regions of the brain that's responsible for regulating your mood and your concentration. That way it expands what I can treat. So I tell patients, if you have a brain, I can treat it now. Because I can look at it, tell you what's wrong with it, and then I can alter it using TMS. That's the holy grail. Now I can be just like my gastroenterologist. I can use this like a vital sign. So when I look at the patient's scan plus their standardized rating scales, their PHQ-9, their GAD-7, their sleep indicator scores, et cetera, now it's telling a story, and I can do something very specific for that particular patient. So what we do to make sure that the insurance covers this is we embed the traditional 10 hertz per second into their treatment protocol when they do their treatment. But we also will include additional locations like F4, which is associated with anxiety. We'll include CZ, we'll include the frontal poles, which is like the front of the brain here, FPZ, because we know these different regions of the brain talk to other parts of the brain so that we can create an alpha wave. Now, the best way to demonstrate this is actually showing you a scan. Okay, so let me screencast a recent success story that's given us permission to share her story. Okay. All right, so this is an example of a brain scan or a spectral EEG. I'm going to orient you this, what we're looking at. So this is the brain from front to the back. The letter number combinations correlate with what part of the brain you're on, and then the odd numbers on the left side. Z means the midline, even number is the right side. So for example, FZ would be the frontal lobe, right in the middle. Z. Okay. So this is the frontal lobe, central zone. This is like your motor strip. Temporal lobe, that's T3, T4, so left ear, right ear. Parietal lobe, and then your occipital lobe, and then your heart. Okay, so front to back of the brain. From left to right is the speed. Delta waves, theta waves, alpha, which is kind of the mid-range that we want, and beta and beyond. So mostly beta on this test. Third thing is the thickness of the band. The thickness of the band tells us how many cells are firing at that speed. Okay, so the thicker the band, the more cells are going at that speed. Okay, so as you can see, sometimes you can have slow wave activity and fast wave activity. So this young lady came to us with severe depression, high anxiety, and sleep deprivation, and history of traumatic brain injury. But we can see that all on this scan. The reason I know that, even without knowing her story, is one, she develops alpha waves at about 7 hertz per second. So typically this wave should be about right here. Alpha wave represents efficiency of the brain, but it's also telling what's the speed that the brain is most comfortable going in. So she's fortunate because most patients with depression don't have any alpha waves in the front part of the brain because the front part of the brain is inefficient. So what we should see is like nice clean peak on these, but you can see this is kind of like a mountain range for her. And there's several regions, especially down here, that don't create those clean alpha waves. Also, you can see the thickness of this band right here in the slow region. So think of this as slow. All throughout her brain is running slow. So what that means in the frontal lobe, which is like the executive center, right? That's the president. It's making decisions. It's responsible for concentration and focus and reasoning and mood regulation, especially F3. That's one of our treatment locations. If that's running slow, then I know she's going to have difficulty with those things. But also, you can see the band is thick over here. That means that these cells are firing fast when they should be relaxing. That typically correlates with anxiety, especially F3 and F4. When you see both of these thick bands, that typically means ruminating thinking or anxiety. Okay? Overthinking. Those are those patients that I can't get my brain to turn off, so they can't sleep. I can see that in this particular patient. I can't get my brain to turn off. And you look in the back of the brain, she's got thickness in all these slow regions. That typically means that when I ask you to meditate, your brain tried to go to sleep. And it usually means sleep deprivation. So the patient had very, very poor sleep, and it shows up in this scan. Next, you can see typically the back of the brain sets the pace of the brain. The brain develops from the back of the brain to the front of the brain. Usually the occipital lobe tells the brain what speed we want to go at. So typically, most patients will have cleaner alpha waves in the back of the brain, and they tend to disappear toward the front of the brain. But you can see this patient, she doesn't have those clean mountains in the back of her head. The reason for that is a traumatic brain injury. So we can tell here, no alpha waves, this kind of broken peak. So what happens, the reason I know this to be true is because like when a nerve cell is traumatized, it goes into like a self-preservation mode. The reason this was discovered was Dr. Murphy, who came up with this. He's not even a psychiatrist. He's actually a pediatric radiological oncologist. And what he noticed was when he would irradiate tumors with the gamma knife, the cells around the treatment location had a fallout area. So they killed the tumor, but the cells around it that got exposed to some of the radiation, with that trauma, those cells would start slowing down. They wouldn't fire right. So what the kids were having was frontal lobe issues. They couldn't remember stuff. They would have poor school performance. They got depressed. They were having, other problems like anxiety and things like that after they got gamma knife. He was trying to figure out, how can I help these children get these cells back online? And he discovered that TMS had the capacity to turn the cells back on. So he needed a way to reliably measure how the brain cells were behaving, and that's where he kind of integrated the spectral EEG into looking at the nerve cells functioning. So basically, what happens when the cell is traumatized, whether it be physical trauma, like a hit in the head, emotional trauma, abuse, concussions, things like that, brain cells tend to slow down. So you can see here, for her, since she got hit in the head, you can see like what's called a concussion band. Concussion band is like these mountain ranges that develop in the head. So she got hit in the back of the head, because you see the occipital lobe has a mountain range. All these have mountain ranges. That shouldn't be there. That should just be one peak. So that says that those cells kind of went offline a little bit, and she has a lot of slow wave activity. So just by looking at this scan, you can tell a lot about how the patient's brain is operating. So the treatment plan is, well, we want to speed these cells up so we can make an alpha wave. We want to slow these cells down. And what she should experience is less anxiety, less depression, because guess what? This is the executive functioning of the brain. This is telling the brain, telling the person how she should feel. So if I can speed these cells up and slow these cells down, she should get a clean alpha wave, and she should have a reduction in her symptoms. So let me show you how that looks in real life. So this was day 1 of her treatment. So if we look back and look at her final EEG, let's see, 14. That looks very different. So you can still see the remnants of her traumatic brain injury, but look here, she's starting to get an alpha wave. Instead of those mountain ranges, you got a very, very clear peak all the way throughout the brain. And I don't have a side-by-side, but we have reduction in the fast activity in the front part of the brain and a reduction of the slow activity. Okay. Now, it's all nice and cool to see it on a graph, but that don't really mean anything. without the context of how her symptoms responded. So we can look at her neurocognitive history and see that when she came into the clinic, there was she had a brain scan. Then we had a time lag between when she could start treatment, so we did her brain scan again and her scores again. So she started out with a GAD-7 of 19, which is an anxiety rating score, which correlates with moderately severe to severe anxiety. She had a PHQ-9 of 23, which is a severe depression. The highest you could score is a 27. And she had a sleep condition indicator score of 3. The lower the number, the worse the sleep. Between 9:30 and 10:07, her GAD-7 went from a 19 to a 9. Her PHQ-9 went from a 23 to a 10. We added the neurobehavioral symptom inventory, so this is like with trauma. That was a 27 at the time. That one didn't really change much. Her sleep got a little bit better from 3 to a 7, but at the end of treatment, her sleep had gone up to an 18. So she's sleeping now. I saw her today. She's sleeping about 7 hours a night and getting restorative sleep for the first time. Her PHQ-9 is 11, which is mild depression. And her GAD-7 was an 8, which is mild anxiety. So this is highly impactful, and it correlates with how the brain changed over time from this wiggly, squiggly mountain ranges to very, very clean peaks. And now we have something objective to guide treatment. I can look at a patient's brain and try to push them in the right direction with objective data, not just subjectively how they feel. And that puts us on par with other, I guess, specialties that use hard data to make treatment decisions. And that's the beauty of personalized TMS. And finally, the side effect profile is similar because it's TMS. So headaches are probably the most common side effect to this. But since you're using a lot less energy, it's a lot more tolerable than traditional TMS. Now the drawback to this is time. So since we're treating multiple locations and not just one location, the treatments get a lot longer. They can be from 35 minutes to an hour. It's still 5 days a week for 6 weeks and then a taper for a total of 36 treatments. If possible, I think 40 treatments actually works better, and it's not necessary to taper it like traditional TMS. But we follow those protocols since we're embedding the traditional protocols to get insurance to pay for it. Okay. However, I think there's so much potential with this because now I'm not just treating a depression location. Now I can treat anxiety. Now I can treat OCD. Right? I can treat any condition that visibly impacts the brain. There's this technology has been used to treat traumatic brain injury, patients with concussions. Dr. Murphy's working with NHL players, NFL players to help them with concussions. This can be used to enhance performance. So if professional athletes have, inefficient motor strips, inefficient communication between their visual cortex and their motor strip, we can use this technology to make that brain more efficient, which may improve their athletic performance. There's also research, and actually the reason that Dr. Murphy really supercharged the research was to treat autism. Because there's evidence to show that the front part of the brain and the back part of the brain are running at 2 very different speeds, and they're not talking to each other. So we can use this technology to try to balance the brain out in children with autism to help reduce some of their symptoms. Now, keep in mind, none of this is FDA approved yet. And this is newer technology, or put it this way, a different application to an older technology. Just like with ketamine, we had an old technology, we found a new application for it. It's not FDA approved yet, but we know it works. So this is similar. This is an old technology with a new application that we have seen work. We just don't have the industry-backed studies yet to get an FDA approval. But so far, we've treated 2 cohorts of patients. I've only had 2 non-responders so far, which is way better than traditional TMS so far. So I see the potential that I think is going to be great. And I hope that explanation of it made it make sense to you. Okay. Do you have any questions about that?
You answered the question that I was going to ask about the TBI on the girl with the crowbar. Mm-hmm. Induced the majority of these symptoms. They see a lot of depression, all these fluctuations of anxiety.
Yep.
And obviously dead.
Yeah, I thought another thing that was interesting about her case was she had poor night vision, poor color vision. That's because of the inefficiencies of these parietal regions. It's your sensory processing of your visual stimuli. So since those parts of the brain wasn't working well, she lost her night vision and she had worsened detail vision. And you can see it got better, but not perfect.
Yeah, the alpha regions align better, but.
So one thing I need to ask her when I see her for follow-up, how's her night vision doing now that she's had this? I think I see her next Thursday, so I'll ask her. Very good. Well, thank you for your attention on that. All right, that's PRTMS in a nutshell.
So basically, Doc, the difference between this one and the other one is that you don't concentrate on the energy as much. You just work with the amplitude and the timing and the frequency.
Right, that's actually a good observation. So if you can see the prescription, the things we're looking at is how many times you want to do it. Frequency is what the speed. How many total pulses you're going to get. The amplitude is like the power. All right. With traditional TMS, we typically almost always do F3 at a 10 hertz frequency. You always get 10 pulses per second for a total of 3,000 pulses. You typically get 20 plus trains. So if you can see for her, she didn't get that. She got a lot less because we were treating these other locations. But we hung around that 10 hertz. But remember, we were using that trampoline effect. So we didn't want to hit it exactly at 10 because it's like, also with that trampoline, if you hit the trampoline at the wrong time, it actually destroys the wave. So I think that's why some patients will complain about some worsening symptoms with traditional TMS every once in a while because it's just not paced for their brain exactly right. And we might actually be accidentally destroying the wave instead of generating the wave because it's one size fits all. Because every so often I'll have patients say, I feel like my anxiety is worse since I've done TMS. And that's possible. I used to just think it was, your depression got better, so maybe just only noticing your anxiety now. But as I've kind of realized like the importance of these wave forms, that it's possible that some of these patients were disrupting some ways when we shouldn't have been disrupting them by accident. So I'm looking forward to see how the research pans out over time as there's more research done on this. So, good question. All right, so let me shut this down. Any more questions before I wrap up? All right, let's get it.